Hello and welcome to another edition of Cardiac Imaging Agora. This edition, I have the pleasure of introducing my colleague, friend, and collaborator, another edition of the multi-modality imaging experts at the Cleveland Clinic, Dr. Milind Desai, who directs many things, including our Hypertrophic Cardiomyopathy Center and clinical operations for cardiology. He's going to discuss hypertrophic cardiomyopathy, current concepts, and diagnosis. Milind, the floor is yours.
Thank you, Weil. Thank you, everybody, for joining on this episode of Imaging Agora. And thank you for the invitation. I have no financial conflicts of interest. However, I am involved in a couple of trials related to hypertrophic cardiomyopathy. These are national, international, multi-center trials. So today, I am going to focus on what are some of the current concepts in diagnosis of hypertrophic cardiomyopathy and how, at least at the Cleveland Clinic, we see this disease and take care of these patients. So what is known or what has been written? Hypertrophic cardiomyopathy is thought to be characterized by LV hypertrophy, which is most commonly seen in the septum as well as the anterior wall. Over the years, data is emerging about its prevalence. In the past, it used to be thought of as about 1 in 500 prevalence. Now, emerging evidence that it may be a little bit more common with a 1 in 200 prevalence. Some data out of New York suggests about 1.4% prevalence. So, but it is not an uncommon disorder. This is one of the most common and well-described and well-understood genetic cardiovascular disorder, and it is transmitted in an autosomal dominant fashion. The key here is hypertrophy is typically unexplained to other clinical reasons like hypertension. That does not mean that hypertension cannot coexist, but the hypertrophy is way out of proportion. A key feature of HCM, as all of us know, is substantial proportion, about 70% of them have dynamic outflow tract obstruction. And the mortality rate is about 0.5%, more than half of which occurred due to sudden cardiac death. Something important I want to emphasize at the beginning is that not all HCM is thick walls, and not all thick walls are HCM. And not everybody that walks into your office with hypertrophic cardiomyopathy needs an ICD. There needs to be some tailored approach to management. And let's talk about it. So here is case number 1. This is a 54-year-old male who I saw a few years back with dyspnea and syncope. So the top left, you see echocardiography, parasternal long axis, which suggests very massive basal septal hypertrophy with SAM of the anterior mitral leaflet. Top right suggests significant posteriorly directed jet of MR and outflow tract turbulence. There is this characteristic late peaking dynamic outflow tract gradient that is over 50 millimeters, suggesting of severe dynamic LVOT obstruction. And the CMR confirms what we just saw in terms of very severe massive hypertrophy and significant mitral regurgitation. On the flip side, let's take a look at this 18-year-old male who presented with dizziness and palpitations and near pre-syncope. So this gentleman, on the flip, unlike the previous case, there is no hypertrophy. MRI confirms there is no hypertrophy. What we noticed early, this is a few years ago, what we saw in this case is there's this very prominent papillary muscle. This person does have genuine SAM with severe LV outflow tract obstruction reaching 120 millimeters of mercury. And this person got very symptomatic when we provoked his outflow tract gradient. So the question is, are these both hypertrophic cardiomyopathy? In the case of the first patient, this is what we call garden variety HCM, provocable gradient, very thick septum, but this gentleman was gene negative. What about the second one? This person has a characteristic provocable gradient, but the mitral valve is normal. There is no hypertrophy. And this person was gene positive for myosin binding protein 3. Okay? So what I've shown you are two diametrically opposite in the spectrum of HCM. And despite the same end result, which is severely symptomatic outflow tract obstruction, one can imagine the management of these two cases would be very different. Clearly, the thick septum guy, you can do a deep surgical myectomy, or even in some cases, alcohol septal ablation and relieve outflow tract obstruction. The second kid, there's no way you can do an alcohol ablation or a myectomy because there's not enough septum. So this is where we have developed an innovative procedure where we work on the mitral valve as well as papillary muscle. As they say, necessity is the mother of invention. But the key point I wanted to make is both these patients are variants of hypertrophic cardiomyopathy. So what are some of the factors to consider in an HCM patient that is symptomatic? Are the symptoms due to outflow tract obstruction? And it could be at rest with provocation, or you may not have outflow tract obstruction. So what are some of the players that add to outflow tract obstruction? Obviously, basal septal hypertrophy. You have to look at the mitral valve leaflets, because if your leaflets are long, they could add to the systolic anterior motion. And as I showed you in the case, papillary muscles, where are they located? Are they multiple, lax? Are they undermining the mitral leaflet, causing outflow tract obstruction with SAM? Sometimes symptoms may be due to LVOT without LVOT obstruction, due to diastolic dysfunction, or often in cases with apical hypertrophy. And very often you see patients with syncope or pre-syncope, which could be due to arrhythmia. So it is important to have an understanding of these. Atrial fibrillation is another common scenario where patients get very symptomatic in this context. So step one is clearly to make a diagnosis and establish a phenotype. All four cases here have HCM. The top left is your garden variety, the top right is your apical variant, the bottom right is somebody with a papillary muscle problem, and the bottom left is somebody with a sigmoid-shaped septum. This is commonly seen in older individuals. Be it as it may, this older individuals, they develop all the characteristic symptoms, including LVOT obstruction. So you have to ascertain, not all HCM looks the same. And echo is the mainstay of the initial diagnosis of these patients. Having said that, CMR in many cases is helpful. In fact, CMR has opened our eyes. It has boldly gone where no echo had gone before. So we have been able to identify a lot of different phenotypes on CMR that we did not really understand with echo before. And the other, so these are four scenarios. Again, somebody with lateral wall hypertrophy, second panel with concentric HCM, third panel with apical, and the fourth one with abnormal papillary muscle. The other advantage of CMR is it's a lot more accurate for wall thickness assessment, especially at the fringes. So if you're trying to decide who needs an ICD because severe thickness, or if you're trying to make a diagnosis, is this 15 millimeters septal wall thickness or less? These fringes, CMR is a lot more accurate than echocardiography. As I alluded to, new phenotypes we have recognized with the use of CMR. One such phenotype is the apical aneurysm. So in the past, we recognize apical aneurysms on echocardiography, but as you can see in the left panel, it is not well visualized till you actually give contrast on echo. That's when you really see it. CMR, you don't need to give contrast or what have you. You can easily see the apical aneurysm and also see the thrombus associated with it. Now, why is this phenotype important? Because based on certain data that have been published, this is a higher risk population with 6.4% risk of an adverse event, which is a threefold than patients without an aneurysm. So if you have a patient with apical variant of hypertrophic cardiomyopathy and you're doing an echocardiogram, I cannot underscore the importance of doing contrast to make sure you are anticipating an aneurysm and are looking for the aneurysm or a thrombus. Step two, always in my mind, is do you have outflow tract obstruction? So you may or may not have resting LVOT gradient. So what we do is we utilize all means to provoke LVOT gradient. If you suspect somebody with HCM, you should be going all out to make sure you leave no stone unturned and provoke the gradient. In our laboratory, we, along with the resting gradient, we measure it on Valsalva. We measure it using amyl nitrite. And I will show you data. We routinely do stress echocardiography, especially in asymptomatic or minimally symptomatic patients, to provoke a gradient. The key here is, if looked for diligently, you will see it in about 75% patients. Now, if you only rely on resting gradient, severe outflow tract obstruction is only seen in about 25% patients. So if you don't provoke, you may miss it in a substantial proportion of patients. Why is it important? If you have obstructive cardiomyopathy, your long-term outcomes are far worse compared to you have no obstructive cardiomyopathy. And the key is here, in this situation, in the right hands, we have a very good treatment for it. We can do a surgical myectomy or an alcohol septal ablation, and these patients do really well. Their symptoms are relieved, and their longer-term outcomes trajectory is significantly improved after a myectomy in vast majority of the cases. So it is important to be on the lookout for it. And as I alluded to earlier, often LVOT gradient obstruction may be latent, and provocation is strongly advised. So this is a patient of mine, complaining of dizziness, lightheadedness with exertion, and he had seen everybody, including a psychiatrist, because he thought he was told that he was anxious and he was making up his symptoms. Till this papillary muscle caught my attention, and when we provoked him, his gradient went from 1.5 meters per second to 5.2 meters per second with clear delineation of symptoms. This patient underwent papillary muscle reorientation, and he's totally symptom-free, almost a decade after his initial operation, and he's doing great. So it is crucial to be on the lookout for this. Stress echo, we do this routinely, especially in asymptomatic patients or patients who perceive themselves as asymptomatic. This helps us unmask latent symptoms. We can nicely ascertain functional capacity. We can look for provoked LVOT gradient, ascertain degree of MR, as well as blood pressure response to exercise. So stress echocardiography has a huge role in a rightly selected hypertrophic cardiomyopathy patient. This is data that we published a few years back in asymptomatic patients. These are almost 430 patients who come to the Cleveland Clinic saying they're asymptomatic. What we did was basically, you are asymptomatic, show me, prove it to me. Only 18%, 18% patients achieved what would be expected off of them in terms of their predicted meds. And what we were able to show is that if you achieve your predicted meds, life is good. If you did not, then your longer term outcomes are not as good. And these are asymptomatic patients. So it is important to tease out the symptoms, and we use all means necessary, including stress echocardiography. Now, not all patients have hypertrophy in the setting of LVOT obstruction. So there's a subgroup of patients who have the OCM without the H. So you have to look for other players causing outflow tract obstructions, i.e. the mitral valve or the papillary muscles. So mitral valve abnormalities come in all shapes, size, forms. If looked for carefully, we've observed in about 15–20% of the cases. So there's a case with anterior leaflet SAM. This is a patient with posterior leaflet SAM. This is a patient. So it is important, the two color panels on the right side, it is important to know, using echocardiography, the direction of MR. if you have mitral regurgitation due to SAM and HCM, the jet is always posterior. If in the patient you have a concomitant jet of MR that is going anteriorly, that is not due to HCM. You have to worry about intrinsic mitral valve pathology. So this is important to know, because trying to do a myectomy in this patient or an alcohol septal ablation in the patient with an anterior jet of MR is not going to solve the problem. You will need to address the mitral valve. The other thing, and as I alluded to, is all kinds of papillary muscle abnormalities. As the more we look, the more we have found. So these are examples of very thick, prominent papillary muscle. This is the bottom left is somebody with a very hypermobile papillary muscle. This is an MRI which shows that at rest there is no gradient, but this patient's papillary muscles are hypermobile, and they could theoretically cause outflow tract obstruction when provoked. And indeed they did. This patient's gradient is well over 50 millimeters of mercury. Step 3 is differential diagnosis, because a lot of what looks like HCM, you could have, it could be a masquerader, it could be a phenocopy. So these are 4 strain panels on echocardiography. The panel on the top left is where there is reduced strain in the septum. That's your standard HCM. This is apical variant of HCM in the top right. The bottom left is the apical sparing strain pattern, the cherry on the top, which is suggestive of amyloidosis. And this bottom left is just globally maintained strain of LVH due to aortic stenosis. And using multimodality imaging, predominantly MRI, you can identify other phenocopies like Fabry's disease, amyloidosis, or even athlete's heart. So always be on the lookout. Is this really HCM, or is there something else to the story? Is there something else to the story? Because, you know, trying to treat amyloidosis in the same way as you would treat a HCM patient is not going to end well. Or taking an amyloid patient to heart surgery is not a very good idea. Why do I say this? It is important to make the correct diagnosis. This is data that we published last year, 2,400, almost 2,500 myectomies done at the Cleveland Clinic. This is a world-class center where experienced providers made the diagnosis of HCM on clinical imaging. And we send these patients for a myectomy. 1 in 5 had an alternative diagnosis that would include hypertensive heart, Fabry's disease, amyloidosis, and we even saw a ton of concomitant myocarditis in these patients. I do not have an explanation for why that is, but be it as it may, even with the best imaging modality, we could often misclassify such patients. That could have, especially if you are overclassifying, if you are misclassifying an amyloid patient, that could have bad consequences. So next is risk stratification for sudden cardiac death. A lot of these patients are younger, and there's a higher than normal incidence of sudden cardiac death. So what do ACC/AHA talk about ICD? It said, apply individual clinical judgment and informed consent. That always, I find it strange. You know, that is, are they trying to imply that in rest of the things what we do, we are not applying clinical judgment and we are just flying by the seat of our pants? I don't know. But bottom line is, you know, this to me, the class 1 indication is not really that helpful. So you have to rely on other things. What are some of the things related to imaging? So wall thickness greater than 30 millimeters of mercury. If you have unexplained syncopal episodes, is it arrhythmic? So here, if you're passing out, is it because your gradient is 130 millimeters of mercury, or you have VT? It is important to know. What is your blood pressure response to exercise? The important thing, as I alluded to, this cutoff, this dichotomous cutoff of 30 millimeters of mercury is important, which is where having precise measurement of the wall thickness is crucial. Otherwise, you know, you don't want to, you know, if you underestimate the wall thickness on echocardiography, then you are putting somebody at in harm's way. Or if you overcall the thickness, then you are unnecessarily putting in an ICD. So there's two ways how we risk stratify. One is the American way, and the other one is across the pond, the European way. And the European way takes into account age, wall thickness, LA size, outflow tract gradient. So a bunch of imaging related markers, whereas the American criteria also takes into account massive LV hypertrophy. They talk about late gadolinium enhancement on MRI. I'm going to come to that. So this is emerging as a newer marker for history of sudden cardiac death. And American criteria also take into account LV apical aneurysm. So these three scenarios, and plus end stage HCM. So it is crucial. Imaging is crucial every step of the way as you risk stratify these patients. Now, there's obviously controversy between the American versus the European approach. One says they're better than the other, and they try to justify why one is worse than the other. Be it as it may, a judicious approach to risk stratification is crucial. I will tell you one thing though, even with the best attempts right now, we think we are good, but we still have plenty of room for improvement. Now, comparing the ESC versus American approach, what this study shows is that the ACC, the American approach, is more sensitive than the European approach, and the number of patients needed to treat with ICD is much lower in the American, using the American approach versus the ESC approach. Now, how can we further refine risk? So this is where a lot of CMR has been done, and a lot of stuff has been written about CMR in the last decade. Not only it is precise for wall thickness and apical aneurysm, etc., but it has an advantage of being able to assess for myocardial fibrosis or using a technique called late gadolinium enhancement. So this is a patient with severe scar. So this is the area of the left ventricle, and the white area is all myocardial fibrosis. This is a patient with apical aneurysm, apical hypertrophic cardiomyopathy with severe degree of myocardial fibrosis. And this is data that suggests higher the degree of myocardial fibrosis, higher your sudden cardiac death risk. This is, again, almost 1,500 patient data from the Cleveland Clinic showing that assessment of LGE, late gadolinium enhancement, provides incremental risk stratification in all groups: obstructive group, non-obstructive group, myectomy group, no myectomy group, what have you. So this clearly has incremental utility in terms of assessing for future risk. More data is coming, and I will talk about it in a second. What are some of the newer cool things we've looked at using advanced imaging? One of them, of course, is strain. And I've had an interest in echo strain for a long time now. And we've published a few papers where we have gone downright comparing strain values to histopathology, strain value to developed and resting tension on myectomy tissue in a translational lab. And we've understood some cool things about pathophysiology using advanced imaging as well as muscle tissue. This large study, again, published a couple of years ago now, where we have shown that assessment of global longitudinal strain can help identify and risk stratify in hypertrophic cardiomyopathy patients. And using advanced spline analysis, we can even derive thresholds beyond which the incremental prognostic value can be ascertained. This is an interesting thing that we saw. I think this paper was a little bit ahead of its time. As you age and in hypertrophic cardiomyopathy patients, what we've seen is that there is an abnormal angulation of the outflow as compared to the inflow. And so the blood, you can imagine, in a normal situation, it flows out normally. In an abnormal hypertrophic cardiomyopathy type situation, it almost has to take a right-hand turn, adding to turbulence. And we have shown that this is also an independent predictor of outflow tract gradient. Something cool. T1 mapping, which assesses diffuse myocardial fibrosis, can be measured on CMR, and lots of work is being done showing differences in T1 mapping, T1 times in different phenotypes of HCM, as well as like hypertensive heart, etc. Prognostic value of this data should be coming with the HCMR trial that is in the analysis phase as we speak. So that brings me to this NIH-sponsored HCMR registry, where we have recruited almost 2,800 patients across North America and Europe. We are starting to see important information coming out of this, and more prognostic data is going to emerge in the next 3 to 5 years. So look out for this trial. So to conclude, hopefully I've made a case in this short time that HCM can be a very heterogeneous disease with a very varied phenotypic expression. It is not all about LVH. You have to look at other players. Decision regarding individual invasive therapies will have to be individualized based on what their phenotypic presentation is. And there is emerging data on new medical therapies that reduce outflow tract gradient. I did not talk much about that, but as the years pass, in the next couple of years, we are going to be seeing more and more about it. Cleveland Clinic is going to be leading a trial where we are going to test a drug, mavacamten, which is supposed to reduce significantly LV outflow tract gradient, and we are hopeful that we can avoid the need for surgery. As I suggested, risk stratification is nuanced and evolving, but the important thing is just because you have HCM does not mean you need an ICD. I think I will end here, and thank you very much for your attention.
Thank you, Milind. This is a fantastic overview. I just, to sum up the what you just said, this is fantastic because it brings the clinical acumen that you have, and it adds to it all the expertise you have in imaging. So the first thing for a person treating these patients is first recognize there are multiple phenotypes. Yeah. Don't be stuck on the hypertrophy, which you made this point extremely well. 2, try to provoke gradients. Don't be satisfied just with the resting echocardiogram. I just actually saw a patient that was earlier discussing it with you today, who actually, if we did not provoke the gradients by any way or tool we have, usually stress echo is great, amyl nitrate is wonderful for that, bike stress test, Valsalva, try to provoke the gradient. So you agree with that with me. Risk stratification, you said, is nuanced. I know you apply echo, you apply the gradients, you apply the wall thickness, the tools we have with MRI for risk stratification. The one thing I want to ask you beyond imaging is genetic testing. How often do you rely on a genetic testing to recommend ICD or not in these patients?
I never rely on genetic testing to recommend an ICD. There is no data to connect genetic testing with ICD. So ICD decision, so first of all, this is a very well-studied genetic disorder, and we have many genes associated with hypertrophic cardiomyopathy, and HCM is observed in many clusters of families. The Amish population is very classic. They have one type of genetic mutation and numerous family members with phenotypic expression of hypertrophic cardiomyopathy. So having said that, in our experience, as well as experience of other large centers, if you take 100 patients that look like HCM, okay, they have a phenotype that an experienced expert would call HCM, and test their genetic genotype in all 100 of those, the positive yield rate is about 40% across different centers. If you have multiple family members, then the yield increases to about 60% or thereabouts. So genetics is still evolving. We are still learning. The SHARE registry from out of Boston is generating very useful data that will be helpful. But you know, there was a time back in the day when there was conversations about a specific type of, if you have a specific mutation that was malignant and you should have a defibrillator. That has been, that has not panned out, and we do not recommend just based on a genotype.
Thank you so much, and thank you for taking the time. I know you're tired. It's the end of the day. Have a nice afternoon, a nice weekend. Thank you, Milan.
Thank you. Thank you very much for having me. Thank you.